welcome to this activity, the evolving role of nutrition therapy in the hospitalized patients, focus on lipids and proteins. I'm Joanne Allard from University of Toronto, Toronto General Hospital, and I'm joined by Mempreet Mundi from the Mayo Clinic College of Medicine and Science, and Joanne Ochoa-Gauthier from the Ochsner Health System in New Orleans. This activity is supported by an educational grant from Baxter Healthcare Corporation. In this activity, we are going to discuss data that inform the use of lipid emulsions and protein delivery in critically ill patients. New and emerging products that can be used, and how these new products can aid in improving nutrition therapy for hospitalized patients. So our first topic is the topic of malnutrition. And we'll start by discussing the scope of malnutrition and efforts to standardize or diagnose malnutrition in critically ill patients. Now, we all know that the prevalence of malnutrition is quite high in hospitalized patients. Globally, prevalence is between 40 and 50%, including critically ill patients. The prevalence depends on, of course, the type of patient population, with elderly, cancer patients, those with gastrointestinal issues, or critically ill patients being at higher risk. Malnutrition, we know, is very important and is associated with a poor outcome independently of other factors. It's associated with prolonged length of stay, post-operative complications like impaired wound healing as well as infection, higher rate of ICU readmission, mortality, and discharge to rehabilitation center. Increased healthcare costs is also an issue, and malnutrition has been associated with increased costs by 30 to 75%, depending on studies and countries. And it can be as high as 300% with additional investigation and treatment. So recently, various nutrition societies came together to form the Global Leadership Initiative on Malnutrition, or GLIM, and reached a consensus on how to diagnose malnutrition. So this group published a two-step approach for diagnosing malnutrition. So Dr. Ochoa, can you briefly review the diagnostic algorithm that was outlined by this group?
Thank you, Dr. Allard. Before the GLIM, there have been a number of attempts at diagnosing malnutrition, and some of them are good and some of them we still use for screening or other tools. The big benefit of the GLIM is that it unifies a way to diagnose malnutrition and to do a diagnostic assessment. And the way it was done is that it brought people from different countries and from multiple backgrounds to create this two-stage assessment or two criteria assessment. One is what we call a phenotypical assessment, which is basically an exam, a physical exam, based on weight loss, based on low body mass index and reduced muscle mass. And then an etiology, which is based on the concept of inflammation as a cause of malnutrition associated with illness. And the second part is the reduced food intake that patients are either subjected through their treatments or are naturally inclined to have anorexia due to their illness. We do use and incorporate that into our practices.
Okay. Now, there are various countries that have developed or adopted different screening tools and assessment tools. And in Canada, we have created this Canadian Malnutrition Task Force that has assessed the prevalence of malnutrition across Canada, as well as look at the impact and the cost. And with this task force, we have also developed a screening tool, which is we call a CMTF screening tool, which includes just 2 questions regarding weight loss and poor appetite. And we have also developed an algorithm which is called IMPACT, which uses subjective global assessment for the diagnosis and the severity of malnutrition. So it's a type of stepwise approach to provide prevention or treatment of malnutrition in these patients. And it has created a national movement, and many institutions in Canada are adopting now that type of screening tool and that algorithm to prevent or treat malnutrition in these patients. So, Dr. Ochoa and then Dr. Mundi, can you comment on how screening and assessment are performed in your own institution? Dr. Mundi first.
Sure. I think, we also value the impact that malnutrition can have on healthcare outcomes. And so we've started to implement the same two-step process that we just talked about. The first step is a malnutrition screening tool that's actually performed by the nurse. As the patient is admitted to the hospital. It also focuses on weight loss and lack of appetite or lack of intake. Based on that, if they score a 2 or higher and are at risk for malnutrition, our EMR actually generates a best practice advisory. And this best practice advisory then leads to a dietitian consult, where we can then go into more detail, gather phenotypic and etiologic variables and make the diagnosis. So we've really made an emphasis of trying to do this for every patient that's admitted.
Okay.
Yeah.
Dr. Ochoa?
So we've also worked a lot on screening. We screen at in different areas, and we're incorporating screening for nutrition in our pre-surgical clinics. And that becomes an important aspect of the care of the patients. We're only started in this process, but we're getting there. In the intensive care unit, we not only screen, but we assess everybody. So we do both and screening. And the truth is that if you look at Nutrix scores or you look at other scores, once you're in the intensive care unit, you basically are at high risk of malnutrition. One of the things that becomes important, though, is that the attitude that we have is that every patient is a patient that requires nutrition intervention. Sometimes the patient can do that on his or her own without us having to prescribe, but every patient has to have a plan for nutritional care, independent of whether they end up being into a high-risk category. And in our intensive care unit, every patient does have an intervention and gets an intervention.
Okay. So our next topic is on intravenous lipid emulsion, new opportunities. And we'll start with saying that the administration of lipid is important for immune and biological function, and there have been a number of new formulations that were introduced. We all know also that lipids are extremely important for energy. It's an energy-dense source of nutrient. And when it's provided in parenteral nutrition, it's in the form of triglyceride. And the structure of the triglyceride consists of a glycerol backbone and various fatty acids attached at the 3-carbon position. And the fatty acid, as we know, are hydrocarbon chains with methyl group on one end and the reactive carboxyl group at the other end. And the way they're classified is that it depends on the length of the chain, the number of double bonds, and where is the first double bond compared to the methyl end. So in addition to being an important source of energy and a source of essential fatty acid with linoleic and linolenic acids, lipids plays an important role in regulation of gene expression, signal transduction pathways, provision of components of cell membrane structure and fluidity. So Dr. Mundi, can you please review the available lipid emulsions and how they differ from each other?
Absolutely, and I think just as you've outlined, lipids are an essential part of any nutrition that we provide. And so for centuries, we've been trying to develop a safe lipid emulsion. A lot of work went into, in the early part of the 20th century, into developing a soybean oil lipid emulsion that was then combined with phospholipid from egg source to make it so that the oil and the water essentially don't separate. And so with this, we had introduction of intralipid or 100% soybean oil lipid emulsion, and that's predominantly been the lipid emulsion that we've been using in the United States. But soon after it was out in the market, we started to realize that soybean oil tends to have some positives and negatives. One of the positives is that more than half is composed of linoleic acid. And this is a carbon-18 fatty acid that's an omega-6. So that first double bond is 6 carbons from the methyl group. And it's an essential fatty acid. So our body can't make it, and we need to procure it from plant sources. That's the benefit. The side effects are that omega-6 fatty acids, as they're metabolized, tend to be metabolized into molecules that generate then pro-inflammatory byproducts. And so this can have a detrimental effect, especially when we're looking at the critically ill population. So very early on, we started to look for other sources of oil for our lipid emulsions. One of the first ones that we looked at was medium chain triglycerides. So these tend to be smaller, between 6 and 12 carbons. They have the advantage, we think, theoretically, of being cleared faster. They essentially can go right into the mitochondria and be oxidized, whereas our long-chain fatty acids need to go through binding with acyl carnitine and then being transported in. So there's theoretical benefit there. We also started looking at olive oil. Its main constituent is oleic acid, which tends to be an omega-9 fatty acid, and it tends to be more neutral, so benefit there. And then fish oil, which tend to be higher in content in terms of omega-3 fatty acids. So with this now, available on the market, we have a number of newer lipid emulsions that have appeared. And as you can see, what that has allowed us to do is essentially reduce the amount of omega-6 fatty acids. So we have, intralipid is still on the market as 100% soybean oil. We've added to it a mixed oil approach. One of those approaches is to use a combination of soybean oil, coconut oil, and then fish oil. That's available as Lipidem or Lipo Plus. SMOF Lipid has used the approach of using 4 oils, so soybean oil, coconut oil as our medium chain triglyceride source, olive oil, and then fish oil, and then clinolipid, clinolic, which combines olive oil and soybean oil. So with this, we're able to reduce the omega-6 content and increase the omega-3. And in the US, these lipid emulsions, the newer ones, are just becoming available. So we're very jealous that in Canada, you've had years to kind of work with these. What has your experience been?
So in Canada, we have the olive oil for several years and the multiple oil lipid emulsions for at least 3 or 4 years. And it has been, both have been adopted very well by different institutions across Canada. They can come in multi-chamber and ready-to-use bags, or they can be used as compounded parenteral nutrition. And some hospitals adopt just one type of lipid, and others have all the 3 types of lipid. For the home parenteral nutrition programs, about half have gone toward the multiple oil type of lipid, while the other half use either the olive oil or still use the soybean oil. And currently we're compiling data. We have the Canadian Home TPN Registry, and we're compiling data. It's a prospective cohort study looking over 2 years whether there's any influence on outcome from one type of lipid emulsion compared to other lipid emulsion. But overall, in terms of prescription, it's the same type of prescription as the soybean oil in terms of you follow the guidelines and you do the prescription. And I am not aware of any side effects or issues that have been raised by the centers that are using the new oil lipid emulsion. Okay. So, few studies have compared the lipid emulsion formulation and talking about the different types of lipid emulsion. So can you review for us the available data?
Yeah, absolutely. And I think as we were discussing, we do have a lot of work in our field to do in terms of trials, because we simply don't have a great deal of data, especially from large randomized controlled trials regarding lipid emulsions. But I think we are reaching a point where there is sufficient data combined from observational trials, randomized controlled trials, and then subsequent meta-analyses that is starting to show benefit in certain key areas. One of those is hospital length of stay or ICU length of stay, mechanical ventilation, as well as infection. And one study done by Edmonds et al. Was also a prospective trial where they essentially looked at all patients that were admitted to the ICU and were mechanically ventilated within 48 hours of admission to the ICU and then required parenteral nutrition for at least 5 days. And they prospectively followed them. This study, unfortunately, was not randomized, and so when we look at the numbers in each group, there were a significant number, almost 223, that were on soybean oil, and then smaller numbers in each subsequent group. But they were able to compare soybean oil to lipid emulsion that contained medium-chain triglycerides to actually lipid-free PN, and then also the newer agents containing olive oil and then fish oil. And when they analyzed that data, they started to see that when you compared individuals who received olive oil containing lipid emulsion to 100% soybean oil, there was actually benefit to using olive oil. Those patients had shorter time to termination of mechanical ventilation alive. They also had shorter time to ICU discharge. Same sort of pattern emerged with the fish oil group compared to soybean oil. Again, shorter time towards termination of mechanical ventilation, and then shorter time to ICU discharge. Other studies have looked at the infectious component. And here, when we talk about the omega-6 fatty acids, in addition to being pro-inflammatory, we also think there's data that shows that they could possibly be immunosuppressant, especially of the reticuloendothelial system. And so when studies have again compared using fish oil versus not using fish oil in terms of lipid emulsions, they've shown a dramatic, a substantial decrease in infection. And this has been shown both for fish oil and other studies, one that used a cohort from China that randomized patients to olive oil containing lipid emulsion versus 100% soybean oil containing lipid emulsion, showed very similar results. Dramatic reduction in infection with the newer lipids compared to the older 100% SMOF lipid. So, with this data emerging, I wanted to ask both of you actually, how are you starting to incorporate this data and this information in your clinical practice?
Well, from our point of view, we definitely go more with the newer lipids. So we use both the multiple oil-based lipids as well as the olive oil, more than we use the soybean oil. And again, the way we prescribe it is the usual way that we prescribe, and we go according to the guidelines. And even in the critically ill patients, if we feel that the patients need to have parenteral nutrition before 7 days because they're very malnourished, we will start with a lipid emulsion, but we will go more toward one olive oil base or multiple oil base lipid emulsion. So we don't wait 7 days like you would do if you would use the soybean oil. So I don't know.
So we do a similar approach. We do have a very unique patient population. We have, on average, 70% patients that are overweight or obese. We have a very high-end, critically ill population of patients that have liver transplants, and another patient population, high risk, with cardiac mechanical support. We have recently started to implement an algorithm that allows us at 48 hours to identify those patients that are going to stay for 7 days or more in the intensive care unit. And those are our targets. And those are the targets to use specialized lipids. I do use specialized lipids, particularly in liver dysfunction. I tend not to use them as an energy source. I use them to regulate immune responses and to get a better inflammatory response.
Yeah.
So when we look at the guideline based on the data comparing 100% soybean oil to either lipid-free parenteral nutrition or parenteral nutrition containing a newer olive oil or fish oil lipid emulsion, the major guidelines have recommended withholding or limiting soybean oil lipid emulsion within the first week, as we discussed. And the SCCM Aspen guidelines, in addition, recommend that if the newer lipids are available, it could be considered to use within the first week. And this is essentially also the Aspen guideline. They also recommend limiting the use of 100% soybean oil due to their pro-inflammatory effect, and to use the newer lipid emulsion recommended in critically ill patients within the first week that they are in the ICU. And generally, in terms of amount, the aim is up to 30% of total calories and no more than 1 to 1.5 gram per kilogram per day, which translates to about 40 to 50% of non-protein calories in some cases. And usually it needs to be infused if we use the 2-in-1 system, 12 hours or more. But I think most of us are using the 3-in-1 system, am I right?
It depends. I do tailor a lot, and so I do have to leave the standard formulas a good amount of the time. But that's, again, because of my patient population. Once they're stabilized, I'm perfectly comfortable going to a more, I don't need to customize the formulas as much.
Okay.
Yeah, same with us. I think we use a lot of 2-in-1, but use the same approach as you do. And also as an endocrinologist, I think, and dealing with this obesity epidemic that we all are, I think I've also realized the benefit that lipids can have as an energy source compared to dextrose alone. So we use the same approach as you're mentioning.
Absolutely.
Okay. So our next topic is to tailor and optimize protein delivery. And we know that protein delivery in parenteral nutrition is another area with a number of challenges and controversies. Many patients lose muscle mass during their illness, and they can also become sarcopenic, which is losing muscle mass as well as muscle strength and functionality. And we have a lot of patients that become sarcopenic. The elderly, the patients that are in the ICU, even the obese patients, there are about 10 to 12% of these patients that are sarcopenic. And we know that sarcopenia really is associated with detrimental outcomes. So when we look at the ICU patients can lose up to 1 kilogram per day of muscle mass. And this is during the first 5 or 6 days alone. And these patients don't get enough protein. Generally, they get half their protein requirement if we base it on 1.5 gram per kilogram per day. There are also studies suggesting that 60 to 70% of critically ill patients already have muscle wasting before being admitted in the ICU. So this really compound this effect and increase further the risk of complication, infections, and prolonged length of stay in these patients. And of course, when they are in the ICU, there's further decline of their nutritional status. So that, of course, also increase the risk. When we look at studies, they're mostly observational, but one example is a study by Elk and colleagues where they pulled all the data of several multi-center international nutrition studies. And they look at the patients who had a diagnosis of sepsis and pneumonia that were admitted in the ICU for 3 days or more, mechanically ventilated within 48 hours, and were enterally fed. And they look at the amount of protein that these patients were receiving. And what they found is that the increased amount of 30 grams per day of protein during the early phase of the ICU stay was associated with benefits like reduced 60-day mortality and more ventilator-free days. So, Dr. Ochoa, I would like to know what you think. How much protein patients need, and what are the evidence to support this?
So we have radically changed our practice in the last 5 years. Initially, we focused on caloric deficit and calories, with the idea that by providing calories, we would preserve muscle mass and preserve protein in our patients. We know that that is not the case. What we have focused now, not only us at our clinical practice, but across the guidelines and in other places, is at delivering more protein. So we try to hit at least 1.3 grams per kilo per day. We tend to use ideal body weight, again, because of what I was saying, the patient population. We also try, and we are working towards creating protocols, because I have a unit that has a lot of elective surgical patients where we intervene preoperatively. And so protein has become our focus, not calories. Calories are important. We give calories, but where we really make a difference is in the amount of protein. Currently, what we have observed is that we give about 30 to 40 grams more per day at the end of 7 days when we follow the strategy in the guidelines. We have, there is no level 1 data on whether giving more protein is going to be beneficial, but there are significant observational trials that tell us that we are doing the right thing. There is only one study in one group that has suggested some harm, and that is if protein is delivered at high concentrations in the first 3 days in the ICU. But after that, every study, every group has demonstrated either a benefit or no change, but at least no harm. So as an example, there was a work by Saul Rugeles in Bogota showing that when he doubled the amount of protein that he gave to his patients, there was an improvement in SOFA scores. Other studies by Ferry and others have demonstrated that there's an increase in muscle strength that is statistically significant. And what we anecdotally see in our unit is that by changing this practice of decreasing and focusing decreasing the amount of calories, particularly by carbohydrates, using specialized lipids, and increasing protein to, again, at least 1.3 grams per kilo per day, we are finding significant improvements, metabolic improvements in our patients. And so we are really happy with that. Now the question becomes, and again, we realize that the studies so far have not shown a big benefit. But the studies have a series of problems. Most of the studies combine high calories with high protein. And what we know now is that giving high calories is associated with increased mortality. So the question is, are we hiding the benefits of high protein because we're getting too many calories? And I think that's what happened in the work by Allen's group and others that have suggested that. But again, studies show a tendency to benefit and no clear harm when used this way. So we are doing there. I am a little bit more conservative than the Aspen guidelines. They tend to be more liberal at hitting 2 or 2.5. The truth is I rarely get there. I could get probably most around 1.5 to 1.8 grams per kilo per day.
So when we look at how to determine patients' protein needs and ensure that they achieve prescribed amount of protein, so you do mention what you're prescribing, but what do you do to determine that they really achieve this amount?
So we monitor this now daily. We monitor protein daily, and that is our focus. What we try to do, and we use the guidelines, like, and this is I think something that is a consensus around the guidelines, is we try to achieve enteral nutrition goals from the point of view of protein. And I'm going to emphasize, we do not anymore think of calculating caloric goals. We do calculate them, but that's not our target. Our target is 1.3 grams per kilo per day ideal body weight or higher in specific patient populations.
Okay. Dr. Mundi.
Yeah, we take a very similar approach, although we are still calculating calorie goals. So our goals are typically to try to reach 70 to 80% of calorie goals for those who are critically ill within the first 3 days. But as you mentioned, often in the ICU, especially enteral nutrition, is going to get interrupted, and so we're also very mindful in using other approaches to whether focusing on ensuring that they get a certain volume-based enteral nutrition therapy as opposed to a rate-based, or using added protein supplements. If the enteral nutrition was interrupted due to a study or other interventions or surgery. So we're typically targeting the same 1.3, 1.2 grams per kilogram. For our obese patients, we're using ideal body weight. In a similar manner, we're typically targeting 2 grams per kilogram of ideal body weight for those with BMIs between 30 and 40. And then if higher, we're even targeting higher amounts, 2.5 sometimes. And then the other group that we have a great deal of are those on continuous dialysis, CRT. And so this is also where we tend to have a loss of protein that we need to make up. So there, we're targeting higher amounts, sometimes even between 2 grams to 2.5. The same thing for our surgical patients. Now with surgical techniques, we'll often have wound vacs and open abdomen. And so those patients, we're also targeting higher amounts and trying our best to estimate how much they're losing from those wounds. So we've done the same approach of not focusing as much on calories, but still establishing a target, but then really focusing on ensuring protein adequacy.
We have a very similar approach, and if not almost the same. What we have become concerned is not only in the first 7 days of developing a protein deficit, but once the patient seems to be doing well, we extubate the patient, get the feeding tube out, and suddenly the patient has 0 protein and 0 calories intake. And we don't know what happens in the next 2 or 3 weeks until they come back to our unit. Now severe demand nursing behind. I do target protein supplementation, and I have become less afraid of using parenteral nutrition, which at some point in our careers was something that was considered bad. I think protein supplementation through parenteral nutrition is highly useful. And I do use it in those high-risk patients where I am going to develop a protein deficit.
So if we think about adding more protein, what are the new products out there that may help us achieve this?
Now, there's a good number in the market, a good number of possibilities. Again, I tend to customize my formulas because of the specific patients that I use. That is useful because of my practice. That probably is not practical in a person that is now stable. but I use the very high protein containing parenteral nutrition formulas, trying to minimize and not hit targets of caloric goals. I do contain my my carbohydrate use, my sugar, glucose intake in parenteral nutrition quite dramatically, quite significantly, because I am going to end up giving some calories in the form of carbohydrates in many different ways, including enterally, or sometimes even with the vehicles of the medications that I give. There are commercial formulas out there that you can select if you cannot customize like I do specific customized to higher protein formulas.
So we are concluding here this session, and in the summary we note that the prevalence of malnutrition is very high in patients in hospital and in the ICU. So it is really important to screen these patients, and for those who are at risk, we need to better assess them to determine if they have malnutrition and the severity of malnutrition. With this, there will be a proportion of patients that will need parenteral nutrition in their nutrition care. And for those who need parenteral nutrition, the new lipid emulsions are really providing more benefit comparing to the soybean oil lipid emulsions by being less immunosuppressive and less pro-inflammatory, and in fact probably having advantages in terms of improving outcomes. In addition, protein is important, and we're starting to see emerging data suggesting that patients who receive more protein have also better outcomes, and therefore this is something also that needs to be taken into account when prescribing parenteral nutrition. I want to thank all the participants and for a very interesting discussion, as well as I want to remind the people that are listening to complete the post-test and evaluation to receive their credit. Goodbye.
Thank you so much.